Good evening, everyone. We'll be starting our webinar, and today's webinar I'll be talking about one of the most frustrating and one of the most difficult problems that we face in IVF, and that is failed IVF cycles, especially patients who present with repeated IVF failures. I will start sharing my screen. Okay. So usually patients, they present to the clinic for the first IVF with a kind of mixed feeling. They are hopeful and they truly believe that doing IVF is going to achieve their dream of having a family. But at the same time, they come stressed out. They are stressed out because of the simple fact being labeled as infertile. They are stressed out because probably they have been treated with traditional treatment for such a long time and it all failed. They all know that it's a demanding procedure at all levels: emotional, psychological, physical, and of course, financial. Now, when they undergo their first IVF and it fails, this hope and this belief quickly change into fear and doubts. Patients start to lose hope. Patients become doubtful about any treatment. They have no confidence in their future. And this stress will move quickly into anxiety and sometimes depression. And patients start to think about the procedure itself. They start to think they should give up, and some patients start to drop out of treatment. And unfortunately, many patients, they drop out of treatment too early. If these patients have continued doing IVF, as long as we're having good eggs, good embryos, good transfers, if they drop early from the treatment, some of these patients could have got pregnant if they continued the treatment itself. Now let's go and check some of the basic facts about IVF itself. Well, the success of IVF is around 30%. And here we're talking about take-home babies. This number definitely looks to be mediocre and has been stable for the past 10 to 12 years, despite all the advancement that we had in IVF during the past few years. But this number is relative. A patient who comes to us with severe male factor infertility, her chance of getting pregnant spontaneously is probably almost 0%. But she will be offered 30% success rate if she undergoes ICSI. Because of this low number, we can understand why we have patients presenting with frequent IVF failures. It is very common to see patients presenting to the clinic with 2 and 3 and sometimes 4 IVF cycles failed. This is quite common. And as I said, if these patients continue pursuing IVF treatment, many of them would have achieved pregnancy. Actually, we don't know sometimes, we cannot explain why patients will get pregnant and why patients do not. We transfer a class A grade 1 embryo to a 28-year-old lady and she doesn't get pregnant. We transfer a grade B embryo to a 38-year-old lady and she gets pregnant. And many times these failures might be due to more than one factor. And it's not necessarily that the same factor is present each time they fail. Now, there are so many factors related to a success and failure of an IVF. These factors are usually divided into at least 4 categories: factors related to the maternal side, factors related to the paternal, and of course, the embryo plays a major role, and other factors like the clinic performance and stimulation. Well, if we start with the maternal factors, age definitely is one of the most important and crucial factors that will determine whether the patient is going to have a successful IVF or not. Unfortunately, age, we cannot do much about it. Lifestyle, we believe that lifestyle is important for the success of IVF, but what kind of lifestyle? What are the major factors that affect the success or failure? We talk a lot about smoking and BMI. Are there any other factors, like pollution and some other factors? The host, the uterus, we all believe that it should be an ideal place for the embryo to implant. What kind of abnormalities will affect the success of IVF? Can we do anything about these abnormalities? When should we treat them? What kind of surgeries should we do? Thickness of the endometrium, this is one of the most important parameters that we measure during IVF stimulation. We pay a lot of attention to the thickness itself, and it reflects indirectly the receptivity of the endometrium. But what are we talking about when you talk about receptivity? What are the things that we should be looking for? And of course, infection in the uterus and its impact on implantation itself. Genetic factors, both in the male and the female, play, although very few patients will have genetic problems, but it plays sometimes a major role. We all know that the immune system is a major factor in implantation itself. But what are the exact things that we are looking in the immune system? What are the messages that takes place between the embryo and the endometrium for implantation? Do we really know what we should be looking for? Thrombophilia, that will cause these microclotting in the vessels that will reach the endometrium and the uterus, and its impact on the growth of the and implantation of the embryo. When it comes to the maternal side, we all know that the more problems we have the sperm, the less chance of getting pregnant. And of course, the embryo. This is a major factor when it comes to implantation. What kind of embryos we are transferring? Are we doing genetic testing to all the embryos that we put back? And the quality. What is the best way to assess the quality of the embryo? Especially nowadays, we all know about the artificial intelligence and its role in the IVF lab. Are we transferring day 3 or day 5 embryos? And of course, last but not least, the clinic performance. What is the pregnancy rate in a certain clinic? And I think the patients should be asking each clinic that they do IVF in the clinic, what is the pregnancy rate and performance of this clinic? And of course, stimulation and monitoring. Are we providing the best treatment for our patient? Well, if I want to choose one factor from all of these factors that I've talked about, probably the embryo is the most important one. We know that most of the implantation, most of the failed pregnancies, even abortions, are related to abnormality in the embryo, genetic abnormality in the embryo. Well, in IVF, unfortunately, we don't have the luxury of having a lot of normal embryos. We call them euploid embryos. It is related a lot to the age of the woman. Patients who we consider to be young patients, less than 35 years of age, 40 to 50% of their embryos are abnormal. So if I have a patient, she's 32-year-old, and I have 10 embryos frozen for her, I know that 4 or 5 embryos will be abnormal. And if I'm transferring these embryos that are abnormal and they are not tested in the lab, these patients will not get pregnant. And the normal embryo will decrease with age. At the age of 38, almost 1/3 will be normal. And above the age of 40, 10 to 20% of the embryos will be normal. These are important figures to keep in mind when we talk about the patient, with the patient, and we counsel her about the repeated failures. These numbers also help us to discuss with the patient the number of eggs that they need to produce for us to secure one normal blastocyst. A patient's 35 years and less, she needs to have 6 eggs for her to secure one normal blastocyst. At the age of 38, 39, 40, we need 11, and above 40, we need around 18 eggs. And we know at this age, it is very difficult to obtain these number of eggs from 1 or even 2 cycles. Now, with this background in mind, I think one of the most important questions that we should ask ourselves is, when should we consider repeated IVF failure as a problem? As I said, many patients who continue doing IVF will ultimately get pregnant. So when should we consider repeated failure is a problem and of concern to us? Is it 2, 3 cycles? I think the best question should be is not the number of cycles that we should do, it's actually how many transferred embryo should have failed to implant to make the diagnosis. How many embryos did we put back in the uterus and the patient failed to get pregnant? And we start having questions about the implantation and the failed IVF. Now, if we diagnose the patient as a patient with recurrent implantation failure, what is next? What kind of investigation should we do? What kind of treatment we can offer the patient? Can we do something? Can we help the patient presenting with recurrent implantation failure? It's very important to diagnose the recurrent IVF failure at the correct time. Because if we diagnose the patients prematurely as having recurrent IVF failure, this is going to lead to unjustified examinations and interventions. And some of them have side effects and carry some risk. And of course, we are going to consume, which is already depleted, their moral and their funds. So we need to correctly diagnose the patient at the right time with recurrent IVF failure. And for us to make a diagnosis, it has been shown that we need 3 factors to be considered. Age of the woman, whether the embryos that we transfer are normal, euploid, or not tested, and of course, the clinical pregnancy rate of the clinic. I'm not going to complicate you with numbers, but I'm going to give you an example how this has been calculated. Now, we know that the implantation rate, if we transfer 1 normal blastocyst, in most places should be between 45 and 65%. Now, if I'm going to tell the patient that she has 90% chance of cumulative pregnancy rate, if I take clinic X that has 55 pregnancy rate of transferring euploid blastocysts, and I have 3 blastocysts for this patient, they are all normal embryos, genetically tested, I can tell this patient that by the time I transfer these 3 embryos, I will tell her that she has 90% chance of having a pregnancy. And this is not age dependent. So I need to transfer 3 embryos to tell the patient that she has a 90% chance of getting pregnant. If I go beyond the 3 embryos, normal blastocysts transferred, then the patient will be considered as a case of recurrent implantation failure. Now, if I'm transferring embryos that are not tested, which is done in most clinics, they will not do genetic testing for the embryos. And I want to tell the patient she has a 90% chance of being pregnant, age is very important. Patients less than 35, I need to transfer 6 blastocysts. Between 38 and 40, I need to transfer 10 blastocysts. Above 40, 15 blastocysts. So what I'm trying to say here is we should not make the diagnosis of recurrent failure very, very early. And once the patients go beyond the numbers that I have showed you, then it is time for us to intervene, and it's time for us to start thinking about a real problem in achieving pregnancy in IVF. Now, once we label the patient as a patient with recurrent IVF failure, definitely this is a very stressful situation, not only for the patient, but also for the doctors. The patients are already have limited financial and psychological resources. They have paid a lot of money during the previous IVF. They are bombarded by a lot of lay press stories, what to do, what should be done. They start thinking about changing center, and many start thinking about dropping out of treatment. The doctors, on the other hand, because of the continuous competition among doctors and centers, they want to keep patients in treatment and they want to achieve pregnancy. So because of this, there's pressure on both patients and doctors to do something. And here we start adding treatment, what we call add-on procedures. These add-on procedures that we'll be talking about will give an impression that we are moving forward. And we try by using add-on procedures to retain the patient in treatment. Sometimes even simply changing the medications will give this impression of moving forward. But the most important question, do we have evidence of the efficacy of these add-on procedures? So if you go back to the table that I have showed you, as we said, age, you cannot do much about it. Let's check these different factors that are mentioned here. Lifestyle factors. Around 65% of doctors believe that lifestyle plays an important role in the success of IVF. Many doctors, they counsel patients about smoking, about BMI, caffeine intake. They want the patients to start their IVF in ideal situation, taking care of their lifestyle before they start. Vitamin D has been used a lot during the past few years as a treatment that will improve the pregnancy rate in patients in IVF. But it has been shown recently that vitamin D given just for the sake to improve the pregnancy rate is not valid, and there's no evidence for that. It's a good practice, but it should not be given to improve the pregnancy rate. The uterus, the host, 85% of doctors believe that the uterus should be ideal for pregnancy to take place. Any abnormalities in the uterus, like a septum, like polyps, fibroids, infections, hydrosalpinx, might affect implantation. And the recommended test that we should do to evaluate the uterus is either hysteroscopy or a good 3D ultrasound, transvaginal ultrasound. As you can see, the check here is an orange check, which means that this is not recommended, but you can do the hysteroscopy and the ultrasound. And if you find the pathology in patients with repeated IVF failure and there is no other pathologies found, then yes, you can go ahead and treat these pathologies. The reason it is an orange and not a green check, it's because we all have seen patients who got pregnant spontaneously with fibroid uterus. We all have seen patients, we discovered the septum incidentally during a cesarean section. Patients got pregnant on their own, even sometimes they reached term. We have all done transfers with patients with polyps that we discovered during stimulation, and we go ahead with the transfer and patients get pregnant. So it's a little bit controversial whether we should treat and investigate this, but I think the logic says that if we find these pathologies, we should go ahead and treat them. Other things related to the uterus, endometrial thickness, as we said, is one of the most important markers that we follow up during stimulation. We all want to have this nice, beautiful trilaminar picture with endometrium more than 7 millimeters. If the endometrium persistently continue to be very thin, despite all the treatment that we might give, then hysteroscopy is indicated just to make sure there is no adhesions inside the uterus. Microbiome profiling, it has been a la mode during the past few years. It has been suggested by some of the studies that if we measure or we check the different bacteria present in the vagina and in the uterus, and we improve the good bacteria, then the chance of pregnancy will improve. But this is definitely not supported by the evidence, and it's not recommended to be done. Endometrial receptivity test, the most commonly used one is the ERA. Again, we have been using it for a long time. As you can see here, we have an orange check and then a red X. Just a few weeks ago, it has been recommended that we can do the test. Not recommended green, but recommended it can be done. But just a few days ago, the people who invented the ERA published a paper saying that we should stop doing this test because so far we don't have a strong evidence that's going to make a difference. So to me, probably endometrial receptivity should not be done. Karyotype for the male and the female, The prevalence of having abnormality in the karyotype is very low. It increases a little bit when we have repeated failure. That's why it might be done for the patients. Immune screening is really quite controversial and quite a problem. 70% of doctors still believe that we should be screening for some immune factors. We do a lot of antibodies, anti-thyroid, anti-nuclears. We do tests for uterine and peripheral natural killer cells. But the latest recommendation and the latest evidence clearly show that these should not be done. And I will show you why just in a few slides. Thrombophilia screening, whether this is for inherited or acquired thrombophilia, most doctors, they believe it should be done. It is green. It should be recommended in patients who have a strong family history of thromboembolic diseases. But patients who do not have a history of thromboembolic disease, it is advised to be done, but not highly recommended. For the male partner, life factors are important. We all know the impact of smoking and BMI on the sperm parameters. Sperm DNA fragmentation, which is one of the most commonly used tests in patients who have repeated abortions and repeated implantation failure, is not recommended. It should not be done. It doesn't make a difference. So just to summarize the recommendation before we go into intervention. If we want to investigate anything, definitely we should check the lifestyle of the patients. Improving lifestyle might have a positive impact on the outcome. Pay attention to endometrial thickness. Make sure that we have a good, thick, trilaminar endometrium when we are stimulating the patient. If there is a problem with that, we need to reassess the problem. And we do the antiphospholipid screening, thrombophilic screening in patients with high risk, with family history of thromboembolic diseases. What can be considered karyotype for the patient, 3D ultrasound and hysteroscopy to make sure that the uterus is normal, there's no pathology in the uterus. Thyroid function can be done, especially in patients with repeated failure. It's a good practice anyway. And measure progesterone if it has not been measured in previous IVF cycle. Measuring progesterone on the day of the pickup or mid-luteal phase are good practice. It has been shown that it might improve the pregnancy rate if we add progesterone in these patients. Investigations that should not be recommended, the endometrial receptivity test, as we said, the microbiome profiling, uterine and peripheral testing, and vitamin D testing should not be done for the sake of improving pregnancy rate. As a routine practice, it's okay, and sperm DNA fragmentation should not be done. Now, what about intervention? I will start with things that should not be done. It's easier for us. Endometrial scratch. We have been doing endometrial scratch for so many years, and we tend to believe that it is helpful in implantation. The theory behind endometrial scratch is that when we injure the endometrium would secrete some substances that are also present during implantation. And when we put the embryo in the uterus, these substances will be present and they will help in the implantation itself. Well, the story of scratch is very interesting. For more than 20 years, all of us have been doing scratching to the patients. This is based on the theory that I talked about, but also on some studies, small studies. Most of these studies are not standardized. Doctors doing the biopsies or the scratch, sometimes before the period, sometimes during the period, sometimes during the pickup. Different procedures were done. So these studies were small, poor studies and standardized. When a review was done in 2015 and used all these studies that I talked about, it showed that there was a benefit. And that's why people continued doing scratch. It was until 2019 when a very large, well-designed study with more than 1,000 patients included clearly showed that there was no value from scratching. And that's why the recommendation now is it's time to stop doing the procedure. GCSF administration, intravenous intralipid infusion, IVIG, all of these treatments that are used to modulate the immune system to help in implantation are not advised. This is because although some studies have shown that they are helpful, but these studies are limited. The main problem with these type of treatment is first, they are expensive. Second, they will take a lot of time. And third, although it is rare, but there are some serious complications from such treatment. Spleen injury, liver injury, renal injury, shock, anaphylactic shock, all of these might be caused by such a treatment. And therefore, it is not recommended to give such treatment to the patients. Using PRP infusion for the uterus, especially when the endometrium is thin, most of the evidence does not support such practice. Intrauterine SCG infusion has been advocated by some studies. Again, there is no evidence. Using heparin routinely for patients, it doesn't help. Most studies have shown it does not improve the pregnancy rate, especially if it is done in patients who do not have a good family history of thromboembolic diseases and they are not tested for antiphospholipid antibody syndrome. Assisted hatching, making this small hole in the zona, the envelope around the embryo, has been used by many labs, and again, it does not improve the pregnancy rate. The interventions that are recommended, again, we go back to the endometrium. We make sure that the endometrium is good, healthy, thick endometrium. If we need to give estrogen to support the endometrium during stimulation, then we can do that. If there is no improvement, then we go for hysteroscopy. If there is any genetic finding in one of the parents, then we have to do genetic counseling and probably advise patients to do PGT. And of course, optimizing lifestyle factors. As I said, the embryo, having a normal embryo is the most important factor in my mind. And that's why PGTA, doing genetic testing on the embryos, I think is very important, especially in patients who failed IVF and they have been doing transfers for embryos that are not tested. There is always a good chance that the embryo not tested being transferred is an abnormal embryo. So it's about time for these patients to start doing PGTA, at least to make sure that we are putting back a genetically normal embryo. If the patient has been doing day 3 embryo transfer, again, it's time to move into blastocyst stage embryo transfer. There is a significant improvement in the pregnancy rate. And of course, if there is any infection, then antibiotics can simply solve the problem. The importance of doing the PGT for these patients is that the pregnancy rate, when we transfer a normal, genetically normal embryo, will not be affected much by the age of the woman. We know that if we transfer embryos not genetically tested, the pregnancy rate, as we said, will decrease with age. But if I transfer a normal embryo to a 40-year-old woman or to a 32-year-old woman, I will give her the same pregnancy rate. That's why it's important to do the PGT. So going back to these add-on procedures that we are forced sometimes to consider and use in patients with repeated implantation failure. We should always consider the cost of the procedures and the time we are spending in treating these patients. We should also think about the side effect, the harm that we talked about whenever we are using some of these procedures. And of course, we should always look for the evidence. Do they really make a difference? Or we're just adding some procedures just to keep the patient in treatment with no real evidence that they are going to help? We need to optimize everything for the patient. And when I say optimize, when it comes to embryo, probably the best way to optimize our embryos to make sure that we are putting a good embryo is to do PGT. We need to optimize the host. We make sure that the uterus is normal. There's no real pathology. If there is a pathology, it should be treated. before we continue doing IVF. And of course, lifestyle is important. To optimize the sperm, lifestyle seems to be the most important thing that we can do and we can suggest to the patients. When it comes to our stimulation, individualized treatment is very important, and sometime adding progesterone, when we measure progesterone, will be of help to our patients. So to conclude, failure in IVF is quite common. It's very common to see patients coming to the clinic with 2, 3, and sometimes 4 IVF failures. It's very important to decide when to label the patient as having a problem with recurrent implantation failure. Many patients, we diagnose them early, and these patients, if they continue doing the routine IVF, many of them would have got pregnant. Once we diagnose the patients with repeated implantation failure, we know that this is a very difficult problem to manage. And most of the time, the embryo is to be blamed for the failure. Patients with recurrent failure, they have a lot of stress, so we need to give them a lot of time. Understand all the pressure that they have. Give them the correct information. Give them time to discuss all the possibilities. Discuss with honesty everything related to the add-on. We should not give them false reassurance. We should always be honest with the evidence that we have. Because many times, all of these add-ons that we have talked about, they are being used just because we need to use them just to keep the patient in treatment with no real evidence for their use. And what is really important is to decide when to tell the patient it's time for her to stop doing IVF. And she should think about other possibilities of the treatment, example, egg donation. So all of this can be discussed with the patient, giving time to the patient, and good counseling to the patient will many times will be much better than using many of the add-ons that we have talked about. And thank you for attending.